Someone calling in, or is everyone here?
No, everyone seems to be here.
All right, Kathy's not in this week.
Carlos too sick to join.
Yeah, Carla is sick.
That's it.
Yeah. Okay.
Ready to start?
Yeah.
Great. Okay. Start the customer experience. Sorry. Ooh, it's warm. Or is it just me? We're going to start the customer experience and marketing committee meeting. The first line of business are the minutes. Any comments on the minutes, questions? If not, can I get approval of the minutes? Approved, second? Second. Okay, great. Okay, first one up, Project Edge, Tomas.
Good morning, everyone, or good afternoon, everyone. It's my pleasure to share with you an update about Project Edge. One, I want to just refresh the group on why we undertook this journey. And this slide is very similar to what you saw in 2023 when MetroPlus actually decided to undertake this journey. Our core systems are ancient by health plan core system standards, and it takes us a lot of effort to implement the continually changing regulation that comes our way. And we have not been able to realize the efficiencies and automation that modern platforms bring. We undertook this journey to address these shortcomings and build an agile system that could quickly be updated to reflect changing regulations and achieve our growth and scale ambitions. So we went live with our first wave of Project Edge in December. And it's a tremendous achievement in that we now have a full line of business that's been on the platform for over 3 months now, and we fully stabilized it. So we are able to provide service to all of our 4,900 plus SNP members on the new platform. Rather than talking about our provider and member experience, which has been seamless, I want to talk about some of the accomplishments that we've internally achieved for our associates and team members using the platform. I just want to call out a few examples. Members on the enrollment team call out tremendous efficiency gains. In our legacy platform, every update to demographics that we receive from the state had to be manually entered into the systems. And if you can think about all the address changes, phone number changes that our Medicaid population goes through, it's quite substantial. Our new platform automates this. The team sees an audit report of all the changes that have been made and reviews it to make sure there's not been any missteps. Our claims teams highlight the automation. Scenarios that previously were all manually processed, be it around restricted recipients or be it around COB, are able to be automated using the new platform, reducing the manual touches and the potential for error. Our configuration teams talk about the modularity of the platform. Every time there's a benefit change, they're able to make a local change. As we're implementing our future lines of business, be it Medicaid or HARP, we're able to take what we've implemented and apply deltas rather than having to reconfigure it from the beginning. This will enable us to be much more efficient as we react to the ongoing changes in our guidance we receive from our regulators. The last item is perhaps the most impactful that I want to call out. It's from our medical management teams. Our medical management teams are used to working in multiple systems, one for care management and one for We're now in one system, which enables seamless integration and handoffs between the teams. I'll give you an example that resonated with me. When a pre-authorization is created for an inpatient stay, it automatically triggers activities for the care management team to take a look at Connect with the Member for our discharge planning activities and our post-discharge planning activities. So it automatically triggers activities for every team that's going to touch the member to make sure that that transition of care is as seamless and as successful as humanly feasible. It reduces the manual error and potential misses in communication handoffs that we had when we worked with multiple systems. We also take credit for efficiency built into the platforms themselves, validations that prevent manual errors, incomplete information, and really it brings us into a top tier system enabling us to move effectively. If we go to the next slide real quick, I want to talk about the roadmap. I think we've successfully went live with our first wave and we've stabilized. Our goals for this year are to scale it to our Medicaid and HARP populations, as well as implement the platform for our outsourced business, our MA and QHP lines of business. This leaves next year for us to move our CHIP, EP, and commercial populations. Two things that I want to call out when I show you these timelines is one is we intentionally extended our timeline specifically for wave 3 to give us the time to focus on the go lives ahead of us and do them right, to continue to ensure that our customers, our members, providers, and the associates in the organization all have a seamless experience from this migration. So we made a conscious decision to, rather than cramming everything into this year, to extend and get it all done right for our stakeholders and customers. I want to talk about, if we can go to the next slide, and I think I talked about some of the changes in the dates. We've officially pushed wave 2 and wave 3, partially because we wanted to focus on stabilization, ensuring experience was seamless, getting it done right, and ensuring that our teams have the time to focus and be able to get us to the right solution for our stakeholders with every one of these go lives.
What type of issues are preventing you from staying on the timeline that you had developed previously?
I don't think that there is a single issue that I can point to as being the reason. I think the biggest issue we had was multiple waves occurring in parallel. So when we were in November and December, when we're talking about stabilization, we had the teams working on stabilizing wave 1. We had the teams working on the requirements for wave 2 and starting to work on requirements for wave 3. And said, look, we can't do all this well in parallel.
Doing your day-to-day jobs.
We can't do this all in parallel. Something has to give. And quality wasn't something that we were willing to compromise. So let's focus on stabilizing first, then we'll focus on wave 2, and then we'll begin our wave 3 work towards the latter part of this year. It really was us trying to do too much at the same time. That's the evolution of our roadmap. Thank you for the question. We'll go to the next slide. Really want to talk about wave 2 and how are we tracking against our new time frame. The answer is, based on all the information that we have today, we're tracking well against our August timeframe. There's two big risks. First one was that in wave 1, we had a quality issue in that we identified more issues than we expected. I'm going to go to numbers if anyone is curious, not too many numbers, but we had a fairly high defect rate. And that means that we identified more defects than we anticipated and took us longer to address them. Our testing for wave 2 begins in April. We'll start testing the components that we had more issues with than we anticipated, provider contracts and benefits. So as we get the testing results, we'll be able to say with confidence, how is wave 2 looking from a quality perspective and what does this mean for our timeline? I'm optimistic. I'm optimistic because our wave 2 benefits are very similar to our wave 1 benefits. And our provider contracts and our provider reimbursement is very similar to our wave 1 provider reimbursement. So the areas where we had the most issues, I anticipate the least issues. But before I celebrate with the victory, I want to see the results of that testing effort tell us something conclusive about it. So we'll have that data in April. Again, we're just starting testing of these efforts next week.
I'm sorry, Tomasz. So through August, you expect to roll out wave 2, but then you'll add 5 months of testing. That's plus 5 months after you.
Maybe a clarification. I start testing in April, next week. I've already got some preliminary efforts underway. So between now, I'm technically done building most of the configuration components. I have an extensive testing window to make sure that I don't disrupt the experience of our stakeholders.
I think my concern for wave two will be more volume and less the specifics, although we did defer some of the development for wave two because we could address things manually with 4,000 people that we cannot with 400,000 people. So there's some development. It's not zero, but it's significantly smaller compared to wave one. So there are a lot of similarities, but I think where I'm more worried is what is this volume going to do? Because even with a smaller volume, we saw some slowness, we saw some, the data conversion issues. Now it's a much bigger universe of data, a lot of volume. So how will the system perform, with this amount of data? I think that would be a new concern that we didn't have in wave one. But, similarly to what Tomasz said, in terms of development, it's much more limited because it's so similar. We will have this concern again as we go into wave three, which is again a whole new development there because it's right commercial EP, etc. But this one, I think it's more of those issues.
Thank you for that update. So in parallel to wave two, we've also started working on our outsourced book of business, Medicare and QHP lines of business. If you can go to the next slide, Angela. There we see a higher risk profile. And we see a higher risk profile because the time window is narrower and there is just simply more net new creation and configuration that has to be done before the end of the year. So if I look at my implementation supporting Medicare and QHP, I've got to put all of my integration with CMS in place. I've got to set up the enrollment and billing platform for these. I've got to configure new reimbursement methodologies for both QHP and MA, and I've got to set up benefits, although there are standard benefits. The lift is much higher than it is for wave two, and the time that we have is very limited. So this is a fairly high risk profile that we have for our MA and QHP implementation. With that said, we're taking every action that we can to stick to the time frame. The teams are working incredibly hard to make sure that scope is clear, that we have a path towards addressing every one of the development items that needs to be put in place. But from an overall risk profile, we all see it as a fairly high risk.
Yeah, in other words, we have two timelines that we negotiate in the contract. Lessons learned. So one for go live January 1st of 26. The second one is go live July 1st of 26. And this, oh, sorry, 20, yes, 27, yes, January 27 and July of 27, yes. And this was the lessons learned. I mean, what Tomasz is saying eloquently is we're not sure that January is feasible. And so that's why we preemptively negotiated the July of 27 for all the reasons that he mentioned. But nevertheless, we're okay. We pre-negotiated the rates with the vendor. We have a backup plan, it's however it plays out, as long as we stick to those timelines, we're fine. Nothing is going to fall apart. There's not going to be any gap in continuity of service. We're fine. Obviously, we want to go live as soon as possible, etc. But even if there is a delay, there aren't any meaningful consequences to the plan because of that.
And these delayed go lives, do they have financial implications for us?
For Health Edge, if we're delayed with the Health Edge wave 2 and wave 3, yes, and they're significant. So it's important for us to do our absolute best to stay on track with the Health Edge waves. Yes.
And that's August of this year, January, and then the third quarter of 27.
Right. So those are, yeah.
The last item that I wanted to touch on, if we can go to the next slide, is just few risks from a risk profile perspective. I think the first one you've already heard, and it's the quality of wave two. It's the unknown. We hope to get that data within the coming weeks as we start that testing effort. The other aspect that is a risk that we've incurred is we've transitioned how we run the program in the last few months. One of our relationships around PMO support has concluded at the end of February, and we've onboarded resources to support Metro Plus in leading, driving, and managing that program. Anytime you swap resources, you lose some institutional knowledge. I think we've done well with that migration, but it's only been a month, and we'll know more as we conclude the first rounds of testing. Any questions? Thank you very much for the opportunity.
I mean, I know it's not consolation for anyone. All I can say is we know that other plans that are implementing Health Edge are also delayed. So it's not consolation. If we're delayed, it's expensive for us to get delayed. We want to adhere to our timeline, but this is not a unique situation for Metro Plus.
Are you still working off your contingency, or somewhere I saw a chart that showed the flow of money from the beginning?
Lauren?
The question was whether we're still within our contingency for the program.
Absolutely. And we have an exhibit we'll walk through later in finance.
Thank you.
Okay.
Everyone, Mr. Mehdi, Deputy Chief Operating Officer.
You want to hit your button?
Thank you. Thank you. And
We're fine because nobody is online, right?
It's the recording.
So this
Oh.
is what?
But the recording.
Oh, the- turn it off.
so thank you for the opportunity to present. I'm going to speak about member rewards. So MetroPlus has a member rewards program that is available to most of our members. And the goal of the program is to increase member satisfaction and retention. It's also to encourage preventive care and quality-driven behaviors and support quality-related metrics as well. The members earn rewards for health-related activities. The eligible activities, some of them I put up there on the list. So annual physical, breast cancer screening, flu shot, etc. And then moving on to things like walking and steps and sunscreen use. So that's, we're adding that dimension to the rewards program as well. It is administered by our vendor in ComConvey since the beginning of 2024. The highlight that I want to share with you here is that we have about 85,000 members on the program. Essential Plan has the highest participation. And over the last 2 years, we have paid $5 million to our members. This is essentially cash for our members. They get it on the form of a card, and then they can go ahead and spend it. So it's a big win for us because we believe that this is a good benefit for our members. All right.
I meant to ask you this during the briefing, and when I saw the slides and I kept on forgetting, so I'm gonna ask now. It used to be that the redemption was the highest in Medicare because we do so much hand holding. When you say it's the highest in EP, it is percent of the population or in absolute numbers?
It's absolute numbers, but I mean, of course, they're
Okay.
absolute numbers, and they are the lion's share, but of course, they are also a larger population. With Medicare, we also give them the rewards card as well, so we auto register them. So so percentage wise, they will be skewed a little bit that way.
Okay.
Yep. Slide. So how it works is that most of our members are eligible. Members are informed through various channels, our portal, enrollment materials, onboarding journey, etc. Once the members are registered, they receive a card in the mail after completing their first eligible activity. So the eligible activities are recorded either through a claims activity load to the vendor. So it will show that they had their annual physical or the event, or member self-attestation. The self-attestation is new. Naturally, we have to use it for things that are non-clinical, like the steps, sunscreen use, etc. But we are also doing it for some of the clinical activities for gold, because we want to make the process as easy as possible for gold members. In either case, no documentation is required from the member, which makes the process very simple, and it's an overall good experience for our member. After each, sorry, do you have a question?
So, if I went and, did breast cancer screening, I then take the card to my doctor, and how does that work?
No, absolutely. It's much simpler than that. When you go get your breast cancer screening, the claim is then, in our system, of course. Periodically, we load the claims onto the vendor system and they register it, and they'll automatically add that balance to your rewards card. So the member does not have to get any documentation from their physician or submit on their own.
Okay,
It's a very seamless
great.
experience for our members. Thank you.
And with EP, they just have to tell, they just have to go in and say they got it, right? You don't look at the.
For an EP, there are two measures there's one related to walking, et cetera, where they go and do it. For gold members, the entire thing is self-attestation. Yes, and I'll show an image in a second of self-attestation as well, but it's a great question. Yes, we're mixing it up a little bit where we feel that the self-attestation is a better thing for the members because they can just go and do it immediately. But of course, the claims reactive is also a preferred option as well. After each activity, the member wallet balance is updated. The member can redeem it at thousands of physical locations as well as online. We added Amazon this year, which is a big win. So members who earn rewards can use those dollars on Amazon for eligible purchases. Of course, there are limits to what you can purchase with the card. Members can carry over rewards earned in 1 year for partial use in the following year. So I believe it's about the first quarter of the next year. And it is our call center that answers all the questions for our members, so they don't have to reach out to a third party, even though a vendor administers it. Our call center is equipped to handle all the calls related to member. All right, we'll go to the third and last slide here. So this is, let's say this is related to the self-attestation. So we began gold, and it's really about gold here, just trying to show our progress in gold. So we began this rewards for gold members in September last year. It's for all gold subscribers. Right now, it's not for dependents. We're looking to expand there, but right now it's just for the subscribers. It was designed with simplicity in mind, and that is why everything was member self-attested. So member can go and say, I did my annual physical, and just put their date, and they check a box to attest, submit, and then within a few days or so, their wallet balance will be updated. The summary of the rewards program is there. So we have annual dental visit, breast cancer screening, flu shot, mental health screening, annual PCP visit, and then we have some movement and sunscreen use as well. Each of these can only be redeemed once a year, and that's and it shows up on your card. And like I said, you can use it in stores or online at some of those vendors.
Movement is a once a year too?
It's once a year, yeah. It sort of says this month I walked X number of steps for that X number of days, and you check it, and that's it. You'll get it for you do that for 1 month in the year, and you get it.
Valencia, I think it's a good question because it sounds silly.
Keep it ongoing.
Yeah, exactly. We should relook at this.
Okay, sounds good.
And see, at least once a quarter, right? Instead of like, you moved today, congratulations.
That's a good for the year.
Yeah.
For some people, it might be actually.
Exactly.
Just to get the 25.
Yeah, just like me.
And any questions on this? Thank you. Okay,
It's
thank
also
you.
a matter of stickiness, right?
Yeah.
If you know that, you get into the habit of
Sure.
going in and attesting more than once a year, it might become more of a habit, and we
Sure.
may have better redemption rates.
Absolutely.
So,
see what we can do about that. We'll
Yeah.
definitely look at
Yeah,
it. Thank
I
you. Thank you
think
for the
we
question.
were thinking about it this morning as we were brainstorming on gold. Like,
Oh.
how do we tell people it's easy because it's self-attestation without people taking advantage of it?
Right.
So do it appropriately, as in, yeah, it's easy, you can self-attest, but then all of a sudden someone goes in and self-attests to everything in the same moment for the same time period. So we'd love to talk to you about how we
Yeah.
send that message to get them excited, but not overextend ourselves, and
Sure, we can look
Yeah.
into that.
how to do it thoughtfully, so we could
Am I
use your help.
thinking cynically because I'm thinking that everybody is just going to
Self-attest.
say, yeah, and say they did.
Yeah, I mean, someone may go in and say, check, check, check to all of them,
So
and I
be
get my
it,
two
but-
hundred
For
and
the
fifty
goal, I
dollars.
mean, I figured you took that in consideration and set
Yeah.
it up.
We did.
So for
We're
our
not
payment-
gonna be the police here.
Yeah.
We're not gonna attach people to polygraphs.
Yeah.
It's fine. It's there to support our members, encourage them. And if they are not using it as intended, it's really on them.
Yeah, our thought was more, do we say it's self-attestation to make it easy and encourage you without saying it? So I think we need
Yeah.
some help.
I
how to
think in
thoughtfully
that
do it.
checkbox there, sort we can even make that wording on that checkbox a little, more significant, kind of make it, we can always use something like that, or say that, it can be validated through claim activity or something, for the ones that can be, we can always add something like that to make it that way, but, I think hopefully, we're hopeful that the percentage of people who would take advantage, the cost of trying to police it would, that would probably even out or so. So it's probably acceptable.
Yeah, and
for us.
word of mouth, I mean, I think people will, I know people that speak about, well, I get this card and I get such and such an amount a year and you should try it. I don't have to do anything. I just go in and say I did it and they give me the card, and which
Yeah.
is what you want.
Yes,
to
we're trying to
encourage
figure out from a
people.
marketing standpoint how to say you don't have to do very much without really saying it. So we could use your help with that one. Yeah, we know we need to dial it up, for sure.
Thank you very much. Thanks for the opportunity.
Okay, good afternoon, everybody. So in the last board meeting, we went over the types of provider inquiries that are coming in. And we want to expand on that in this quarter's report. Metro Plus Health supports the no wrong door policy. So our provider network operations takes in any provider inquiries, any complaints, in any avenue that any pathway for which we could receive it. And that would be either through the provider call center. We hold many monthly joint operating committees, JOCs. We have a general provider inbox, which we get thousands of emails on. We also provide access and availability education to our provider community, and that is another avenue for which providers can bring up any operational issues that they're encountering. And something new that we also implemented in 2026 was a direct hotline into our provider network operations from our growth team who are out in the field. If they are at the physician's office and they have any questions or concerns, they are able to warm transfer that provider directly into our provider network operations, and we will follow that inquiry. And we're also setting up a doc-like experience for our provider community where they can schedule an appointment, and we will meet with them via Zoom or Teams and go over their issues. And so a lot of good, exciting work to make sure we're accommodating our provider community. All this is then tracked in Salesforce, or we open up an IT ticket if it's a configuration issue. The IT tickets call it a CPI, which I will reference later on in the future slides. So next slide. I presented this at the last quarter and how we ended up in fourth quarter 2025. You'll see that we saw a steady decline in provider calls coming in. The green, the claim status, claim dispute, claim inquiry are pretty much has a common theme, and we are seeing a decrease in that quarter over quarter, and that's attributed to more timely claim payment accuracy, as well as our provider network operations team working with our provider community and addressing things more holistically and mitigating those reasons for providers to call. And so these are our top 15 categories that drive 95% of the inquiries coming into our call center. Next slide.
Well, I'm, again, apologies, I didn't really see that trend, but offs increased, somewhat significantly.
So authorization is the primary driver of that is the calling of to see whether CPT code requires an authorization. And you'll see that in the next slide. And so we are getting ready to push out a tool so that our call center reps will be able to identify if a CPT needs an authorization, but we also will be publishing that to the public so providers can type in a CPT and be able to determine whether authorization is needed or not. A lot of those calls are coming in, or they're calling because they thought they had put an authorization on file, claim denied. So it's more of those sorts of inquiries. But we're
Yeah, no,
hoping that
I
it'll minimize.
understand. I'm just worried,
Yeah.
it went from 38 to 46. So that's not what we want to see.
Yeah.
And then we were working specifically on BH providers, right, to address this issue,
On the injectables,
not injectables. Put a CPT
Yeah, yeah,
code
that's,
and,
that's just separate, yeah.
Yeah.
but
and
that,
so-
but that's just for BH. That's not across the board.
No, it should be across the
It's
board.
across the
It's a
board.
CPT.
It will be
code.
across the
It's
board?
optional because we had a very antiquated a couple
Yes.
years ago. We wanted to make it more sophisticated tool. And the team, IT
There
has
are no
been working
multiple
on that.
grids, blah, blah, blah. So
Yeah.
I remember I was just creating that AI tool.
Yeah.
So, Malik is working with Terry.
Yeah.
So-
it's a great
Right,
tool.
but there's, what we heard from providers is that they're skeptical if they just look this up. They're skeptical that they will ultimately get paid. And what we heard was that they wanted from you, from the survey that we did with providers. They said, it's not enough that I can just search it and show whether, that a certain CPT code doesn't need an auth. I want proof. I want to be able to print it
Pull it out
out
there.
so that when you deny for no auth, I can show this to you. So the new solution will have
Yeah,
this
it
ability
go-
to
it-
print out evidence?
Yeah, it goes to the, yeah, exactly. It goes
Okay.
directly to the CPT code. There's an auth required or not. Specifically, instead of it hallucinating to think that that
Yeah.
is there, the specific language, so they can print it out.
Okay, and there's a print
No,
option.
That's not, they would have to screenshot it or print it
Yeah.
from their own.
Okay, so
yes.
Yeah, we don't have a print from.
Okay, so we need to look into it, because
Okay.
that, in the survey, when we interviewed providers, that was the specific issue that they talked about. Can I print it and keep it for my record so that, I'm seeing it now, but then when you deny, I can show you, you told me that I didn't need to submit an
Is
auth.
the
So
search history stored in this?
That's what I was thinking. I was wondering whether.
I don't know if it is,
No,
but,
no.
okay, then it's not.
So let's just look into that feature, because I think,
Yeah, because it's still a browser. I mean, the print from a browser exists where you can just print out what you're seeing, but we don't have a specific button. for it, so
I
we can-
know,
we
but
can put-
not,
Yeah, we can put a button
not
there.
all the users are
Yeah,
sophisticated.
maybe we can put a button there to which it actually do it.
Yeah, it'll just call that function.
Yeah.
It's called, but yeah, it solves the problem. It
Yeah.
Calls the function.
But you would know the data that the provider saw on whatever date and time he called, right? You would be able to know the construct, like if they said, well, we checked on February 6th, you would know the CPT codes and
So
whatnot.
we're
that you
not,
would have then.
so we're not storing all the search queries that anybody is typing in at any point in time. But if they print
Not
it
the
out.
search.
No,
Right.
Valencia is saying we would
The actual
know,
data, you know
Yeah,
what
yeah,
data you
because-
have on your system to be
Correct,
able to
correct,
validate it
Yeah.
on
It's-
your own, but they just don't trust you.
It is version-
there is a long history,
Yeah.
right, between providers and plans
Right.
that we have to
Yeah,
tackle.
we update
I
it.
was just thinking that,
Yeah.
I know that they had the ability to do that before.
So the top provider issues that are surfacing in our first quarter JOC meetings that we have with our providers. One is we did a system modification in October of 2025, where we removed certain services. We're denying certain services that are not covered on the Medicaid fee schedule. There were certain codes that were inappropriately removed, and it caused our providers some provider abrasion. Our IT team is going in and we're reconfiguring the system to ensure that we are taking into consideration those additional codes that should have been left in. And as a measure to prevent that from happening in the future, we are going to be applying more stringent rules so that if a business area submits a request to IT to make a modification, a technical requirement document will need to be created with business area sign off. So this will provide a more tightened process to make any system modifications that would impact our claims engine. The second item that caused an increase in provider calls that we're experiencing in the first quarter is the EDI processing delays. When we did go live and we switched over to HRP, through that migration in December, on December 5th, we went quiet, we went dark in our current legacy system so we could migrate the claims over to our new system. We then turned on, so we stopped loading EDI claims, we just stopped processing claims during that dark period. Then in the middle of December, around December 15th, we turned the lights back on. We started to load claims into our legacy system as well as our new HRP system. As that happened, there was a delay in how we were processing and loading in the EDI files where we had to parse out the PIC claims. And so it's a manual process. And so it took us about a month to catch up. But because of that, in 2025, our providers were getting used to the speed for which we were processing claims. We were processing claims quickly in terms of within 15 days and 30 days, which I think the providers were very happy about. They were getting paid more timely and accurately. But because of that, providers were used to that. And so they were calling us saying, what's happening? We're caught up and it's been fixed.
Wasn't possible to notify providers beforehand that there'd be this dark period?
We preferred not to. I think we were trying to fix it, and we were keeping them updated as they were reaching out to us. And our provider relations team was also keeping them updated, but we were still getting phone calls.
Maybe just two things to add on this topic. One is it was planned, right? We planned to have the cutover, which meant holding the files for a little bit.
Right.
Two is we were able to meet all of our contractual commitments of processing within 30 days. So they weren't
Okay.
impacted from the perspective of us not meeting our commitment. They just weren't serviced as quickly as they're used to from our excellent service.
Correct. And there might have been some bleed over, but it's because they were used to getting paid so quickly in 2025. They were calling us saying what happened. But in the reality is we were processing within 30 days prompt payroll. The third issue was claim denials and underpayments. It's typical, but what we saw was that we were having claims denied inappropriately or underpaid. Most of them had to do with contract configuration issues, whether it was benefit or provider contract configuration. But the IT team and operations team have worked together to implement a more peer-to-peer review, a more tighter UAT testing. And so that is something that we'll continue to work on in 2026 to make sure we strengthen that arm so that we prevent inappropriate claim denials and underpayments from happening. The fourth item is the provider authorization tool, which we spoke about. We're really looking forward to push that out into a production area. And then the last one is the delays in regulatory rate updates. In 2025, we saw insurmountable amounts of state directives with rate updates. And so that really bogged down our queues in terms of doing mass adjustments and doing configurations related to regulatory updates. And so providers were calling and they were asking for the status of when those regulatory rates would be configured and when we would do a mass adjustment. So we continue to monitor that very closely and working with our IT team.
Didn't you just blame the state?
Did I just?
For the rate updates and whatnot, when they were angry about that, then you just.
Oh, did I blame the state? Well,
I mean, everybody.
I think everyone knew.
Recently just got another massive.
Yes.
Yeah, I mean, I think it's legitimate to blame the state.
It is.
because I
It
think
puts us
the
in a very
delays-
uncomfortable conversation. We have to
Yeah.
meet with all the systems and all the providers and explain to them. And in addition, because of our integrated system, we could only process X number of claims. And so it's like a domino effect. And we continue to keep our providers abreast with that. Next slide. So just to give you an idea of what we're facing here. So I had mentioned we get 1,000 emails in our general inbox. We did like 960 access and availability presentations with our provider community. Is another pathway for which we'll hear provider inquiries. Growth will provide feedback as well. But all of this is captured in Salesforce. And so a lot of the cases are open and close. It's basically a win-win situation. They're easy fixes. Those that need to be escalated, our provider network operations team will put a Salesforce ticket. It may need to go to IT for fixing or contracting. And so there's a key stakeholders for which we work with. The average turnaround day there is about 27 days. And then we have also other escalations that come in from other teams that we continue to work through. And then also we do have the call center opening up tickets as well. And so this is just, we're tracking it and when we get into a future slide, you'll see that we are going to do a more corporate enhancement to have a centralized database so that we can see everything that's happening with the provider community in a holistic way to identify training opportunities, communication opportunities, quicker system changes and so forth. So I think this is going to better position MetroPlus in terms of providing a better experience or continued better experience for our provider community.
Aliva, one of the things that I was thinking about when I was looking at the slides is whether you're doing a lot of touches with the provider and a lot of enhancements to presumably make their lives a little better and more efficiencies in the plan. Has that transitioned over to improving access and availability at all? Or have you not had the opportunity to check that yet?
I haven't had the opportunity, but I do think that our provider experience has improved.
You would think.
Yes, over the past couple of years, I
But
think
it
it
would
has
be
improved.
interesting to see if it-
Yeah, we could share that at the next meeting.
It'd be interesting to see.
If it's a proxy, our CAP score is improved.
It's
Oh, that's
significantly
good.
improved, very, very much so. And I
Did
think
it
that's
really?
because of access and availability, accurate information. So I think it's a domino effect. We do a lot on our provider directory. We do secret shoppers. And so
Right,
there's a lot
right,
of activity
right.
happening behind the scenes. And so we do think that
But that's a good marker.
what we're
though,
hearing.
if that's improved.
Yeah.
Yeah. By a lot.
Yeah, we even track NPS post calls when they come in, and I was just looking at our sentiment for the last few months. We haven't gotten as many NPS ratings because we haven't gotten as many post calls that had an issue. So that's a good tracker too, if there's some abrasion at times. So it's a little bit of
Yeah, yeah.
everything.
And I think a provider satisfaction survey also had mentioned that the provider relations and the interaction with the provider community has been helpful.
It was
It's been
increased.
beneficial, yeah. Next slide. So this is where I mentioned the CPI tracking or IT tickets that we opened up. So you'll see over the year, or approximately a year, we opened up over 3,000 tickets, of which 2,600 had to do with the configuration change. So it's a provider maintenance, whether we needed a W-2 form for the provider, a TIN number update, also core benefits, and then core pricing issues. And so we further broke out the 2660 into other categories. So we had 109 regulatory cases that were opened up. So the cycle time there was approximately 59 days. So some could be much greater and some could be a lot smaller. So it's average of 59. Previously, earlier last year, we had introduced a SWAT team. The SWAT team is a dedicated group of individuals that will help us address all the regulatory demands that are coming down the state without distracting the rest of the workforce so that we can work on Project Edge and the day-to-day activities. So those directives, we submit a ticket in, average cycle time is 57 days. And then we had just the normal mass adjustments related to any contract configuration updates or benefit configuration updates, and that cycle time is about 58 days. So the average CPI ticket is usually around 30 days. You have easy wins, open, close, and then you have those that could be 120 days, but the average is 30 days. Next slide. And this is just an idea of how we're getting the top 10 inquiries coming in from the different areas. And again, still working a close partnership with the IT team, making sure QA is tight, UAT is tight, so that we can minimize the opening of CPI tickets because of rework or contract configuration issues. And so that's something that we continue to partner on in 2026. Next slide. So how P&O tracks all the inquiries and make sure that we close it, we have a dashboard in BI. So we're able to see all the pathways for which an inquiry comes in and we track it to closure. The P&O leadership team meets weekly or bi-weekly with the IT team and escalates any CPI tickets that needs to get addressed because a provider is causing or actually ringing the bells. But we also try to make sure it's not the loudest person in the room screaming. We have to be very thoughtful in terms of prioritizing the CPI tickets. We do have many internal escalation meetings. We have one with provider network operations, the claims team, core. We have one with P&O and the customer service team. So every pathway for which a provider can connect with us, we have meetings so that we're all on the same page and we can prioritize the work and make business decisions based on what we're hearing. And then the last part is the central repository, which I mentioned about that we are creating that. I am excited for that because that will continue to benefit our provider community. Next slide. Okay, so telehealth. We reviewed the 2025 telehealth utilization from both a virtual experience as well as Express Care. Telehealth utilization for 2025 accounted for 12.72% of all outpatient visits, with Express Care accounting for 3.5% of the telehealth visits, or Express Care made up 0.4% of all outpatient visits. When we compare 2024 to 2025 data, telehealth utilization went up 6.8% year over year. Express Care went up 23%. When we looked at the data, and for which I'm going to be presenting to you in the future slides, the demographic analysis, it's utilization measured by age, gender, race, ethnicity, geography, and we normalize that by 1,000 members so that we could do an accurate comparison.
Remind me, did we add Express Care number on the back of the card?
Let's start, I mean, the new cards, we're actually have a meeting
Yes.
today to discuss some of that. But yes, that is, it's now designed. We just need the approval to go through with it.
Okay,
we-
so
we
it's
need
not
that.
there yet.
It's not there yet. I think it may have been approved for Medicare already. I'm not sure. We have to look at which ones are approved. We'll get an update at 2:30 today.
Right.
But it's, the markups are ready. Everything is ready to go once we get approval.
Okay, because I think when people need care, they don't remember what we have. They need to be.
Yeah, so it goes out in our new member guidebooks. It goes out on, we have it on the IVR. We have it more front and center on the website, I believe. And so we made some purposeful changes in 2025 to bring awareness that telehealth Express Care is there. So I think that contributed to 23% increase, but there's also more room for improvement in 2026 that we will be collaborating on to make sure that it's, again, access to care. Express Care is easy, it's an easy tool to use. So we want to make sure that we amplify that.
Could you remind me the difference between Express Care and telehealth?
Sure. So telehealth is you schedule a doctor's appointment or mental health, and Express Care is the H&H Express Care, where it's a 24-hour.
You go to the hospital.
No, you dial in.
It's telehealth, but it's
It's
HHH.
telehealth.
Oh,
It's
it's
like an
HHH.
urgent care online. You could do mobile or
Okay.
QR code. Yeah. Next slide.
I think we should do some research to see if a separate card, market research, if a separate card that only says, right, Express Care in addition to our membership card, whether that will be more effective than adding. I mean, we will add to the back of the card
Right, of
regardless,
course.
regardless. But let's see if we can have more uptick if there's a second card.
Sure. I mean, we were thinking of that, or, something like a fridge magnet or
Yeah.
something, where you just have it in your home, you put it in your fridge,
Yeah.
you go there.
Or that.
So
Yeah.
that, so those are things that
Is
we
there a
are considering.
preference of you wanting them to use Express Care versus the regular telehealth, or you're just thinking?
So usually, I mean, I'm overly generalizing. The usual telehealth is I want to see my doctor. They don't need to, so it's usually for routine visits, for follow-ups, etc. Express Care is more urgent care online. So especially after hours.
The telehealth can be used the same way, right? It
That's
can
what I'm
be,
saying.
but
I'm
just-
generalizing,
Okay,
right?
okay.
Like if you have a provider with NYU also offers an urgent care line.
So Express Care is more like sick visits.
Right. Express Care is dedicated essentially to it,
I see.
although it does provide some maintenance care for behavioral health. So there's a twist there. So I think to communicate all of this, so it's great that, I definitely want us to add the phone number on the back of the card, et cetera. But I think if we want to say a little more, it's physical care, it's BH, you need more space. So where are we going to find the space, and how are we going to share this with the members?
We can look at that, absolutely. We'll look into either a separate card or maybe a combination of both. I think just to add on to the Express Care, the one of the big advantages is no appointment. You just go ahead and do it. Where telehealth, you have an appointment with your doctor. Are they available at
Oh, that's
9:30?
big.
And are you going to do that virtually? The whole point is you can go anytime.
So you can just call up Express Care and.
Yep. It's like City MD.
Mhm.
Yeah, you go
Just
urgent care
Yep.
on the phone.
Yep.
I think what we don't know with it,
I
frankly,
like that.
because I know for us, talking about it in a way that doesn't confuse a person,
Mm-hmm.
it's like I'm sitting here thinking about this and I'm
Yeah.
like, I need to go back and look at how we're talking about it. Because could it be confusing someone?
It is
If we
confusing.
have to think
Little
about
bit.
it, we have to think about it. Also, let's discuss how we do the research, because we could do it through Macorba survey, or maybe you can do it. Let's figure out who
But
should.
that, that's a key difference though, right? Just
Yeah.
as using kind of like urgent care for the telephone. It's
Yeah.
like
Yeah.
telehealth urgent care.
Yeah,
It's a big
that could be
distinction.
like a good way to.
'Cause I didn't
describe it.
understand that difference.
Yeah, I had to think about it now as we
Yeah,
were
yeah,
saying it, like,
yeah.
okay, how are we talking about it? So we'll
Yeah.
take a look at it.
We could go into the next slide. So just utilization at a glance, younger adults are actually the ones who are using telehealth. It peaks at the ages of 18 to 34, and then we see a steady decline as the groups get older. The gender difference, females are primary utilizers of telehealth. And then from a race and ethnicity standpoint, it varies across race and ethnicity, and there are some groups that are underutilizing it, which we can address. And it could be because of digital access and just overall trust with the telehealth or virtual care mode. Next slide.
Do you think people use it for children?
Yes.
Mm-hmm. Oh, yes.
Yeah.
Yeah.
So, and I think that's why a lot of women are using it because of pediatric and pink eye or something of that nature. From a racial and ethnic difference, what we saw that Black African American, so that they make about 28% of our membership. And we saw that 28.42% unique members utilize virtual or express care. And so of that 29% used it. So it's about 5 per member, 5 visits per member, which it broke out to. In the other category, it was 81% of others is Hispanic and Latino. They make up 24% of our demographic, and you'll see about 5.35 visits per unique individual. And then you'll see the greens, you'll see 2 or more races. White are also using it more than the other ethnic populations. You'll see 8.45 per visit per member, or 6.84 visits per member. And so the call out here though is that Asians are disproportionately underutilizing it. So that's the 15% of the population. And then 14.51% are the distinct members that are using it, or 3.38 per member. So it's an area that we can focus in on. It could be in education, working with the community, letting them know that it's available so they have access to care at their fingertips. Next slide.
Mark, have you ever used it?
Yes.
The regular telehealth or the express care?
The regular.
And you like the experience?
Yeah, it was incredibly simple, direct, and really efficient. I purposely did it to try it because I like in person a lot better, but I realized that was something I needed to overcome, a bias to work through, and I found it to be pretty great. Not as wouldn't say satisfying, but not as great as a in-house visit, but incredibly efficient. So the efficiency made me a happy guy. That was pretty good.
And are you aware of express care, that's an option?
No.
That's the point. I mean, I know it's an N of 1, and I always say we should be careful with an N of 1. But Mark is on our board, and he's hearing what we're saying. We give ourselves a tap on the shoulder, and our members don't really necessarily know about it.
And to Valencia's point, I think just calling out express care is City MD virtual is probably an important message to get across.
The no appointments is big.
Yeah, no appointments, just walk in or call
Yeah.
in.
Calling, yeah.
So the type of visit broken out here, you'll see that outpatient behavioral health visit is the number one, 69.35% of the virtual visits. And then for express care, it is urgent care. It's 75.34%. So next
I'm
slide.
sorry, wait,
Yep.
what was the distinction you were making? I'm sorry.
So virtual visit is your telemedicine visit. So I will go ahead and schedule an appointment to meet with my psychiatrist, let's say,
Okay.
versus a virtual walk-in,
So
which is 75.34
That's
is
what the
urgent
urgent
care. Yes.
okay.
Okay, next slide.
It confuses me a little bit because H&H has express care sites on
Yes.
site. And so, but to use it, you have to go there.
Yes.
You don't make a phone call to use their express care units, right?
Right,
But we have a phone option.
right,
isn't it?
yes. It's actually, I think, physically operated from one of the Express Care locations
Oh.
at Lincoln, yeah.
Oh, okay.
So utilization by line of business, you'll see that Medicaid, can you go up a little bit, Angela? So Medicaid utilization is proportional to our membership, 57.92, utilizing is 56.12, five visits per member, it's averaging. What we're seeing is that EP, there's underutilization, so 28.8% of our membership is EP. But 23% is using it. 23% is the Signature members, but you'll see 18% virtual and 17% express care. So an opportunity to let our EP membership bring awareness that they have this at their fingertips if they need to see a provider quickly. And you'll see for HARP and Gold, they are using it a lot more than the other product lines. The next slide.
We do messaging to members after they visit the ER. Or care, and, to say, hey, by the way, if you need this option. It's based on certain criteria. It's not every single time, but there are some UM manages that.
When people leave the ER and whatnot,
After
that's
some time, yes, exactly, just so that they have it, that they know that that's an option. So we just need to, it goes to that, the link is there, but then that, the next time you need to use it is 3 months later, and that link
Right,
is still out,
right,
so we
right.
just have to make that more, that'll help a little bit. We're looking at that as well, how to enhance that, and hopefully that'll increase some.
But that makes a lot of sense to share that information
Yeah,
after
absolutely.
ER hospitalization, depending upon what it is. But
Actually, not, so yes, ER and hospitalization. Do we also follow up after in-person urgent care visit?
Yeah,
mm,
that's what, it's urgent care and ER, I think it's both that we follow up, and I'll check, but I'm pretty sure
Yeah.
that's what we were doing to say, hey, by the way, and it was, we are also looking at who are the more frequent utilizers. We know that there are people who go all the time, you won't be able to change their behavior, but there are people who go maybe 4 or 5 times a year. You can, change 1 or 2 of them, and that'll make a big
Yeah.
difference.
But why would we be picky? Why would we even have logic? Why wouldn't we send it to everyone?
We could. And it may be that, I believe there was some logic initially, but I think there may be, so I'll check though. I mean, we can just do it to
Yeah,
everyone.
I think the only people I would exclude are ERs that resulted in the hospitalization because we will look like jerks, right? You got hospitalized for a stroke, next time call Express Care. So, if it's ER to hospitalization, I would exclude those, but otherwise,
Otherwise, okay,
Yeah.
that makes
yeah.
sense.
Is the outreach through a direct call or is it through the IVR?
It's, maybe a text line, like text cafe, but so I'll check though with, Keith runs it, Keith McMaster. So
Yeah,
make sure that-
okay, I'll double check.
Yeah.
that. I can ask them that.
So next slide. So to optimize virtual care, focusing on increasing express care, I think focusing on, so optimizing virtual care for younger adults, because they're heavier, they use it more religiously, I guess you could say. So focus on enhancing the virtual care experience with reliable access and a seamless experience for the younger adults to sustain engagement and to grow, making sure that they are aware that it's available for them. Expand telehealth among older adults, so simplify technology, provide caregiver support to increase telehealth adoption among older adults and low utilizing segments. emphasizing the after-hour ability, callback option, wait time transparency. So if you're sick at 11 o'clock at night, you don't have to wait in the morning. You go call Express Care and get some guidance from a provider right there and then. Prioritizing equity-focused initiatives, promote culturally relevant communication, translation, digital literacy, community partnership to address demographic disparities and bridge access gaps across races and ethnicity. I did mention that Asians are lower utilizers, so we could get within those communities and educate our members in those communities about the convenience of Express Care and telehealth. And so that's something that we will focus on in 2026. Next slide. So just going over retention efforts. So you'll see the blue is 24 and the yellow is 25, just to level set. We did experience headwinds in May and June. Our goal was to hit an 80% or greater recertification rate in 2025. We did not hit that, particularly in June forward. There were headwinds that were met. There was the auto renewal of our members stopped in May. And so we saw our HRA, SSI, particular population were hit significantly where they were no longer auto renewed. We had bad, outdated demographic information. They were just hard to reach. A lot of them lost eligibility. And so that was a headwind that we had to come over. As well as the political climate, we saw hesitation of an apprehension of our members, particularly in our EP3 and EP4 lines, where they were not completing the renewals. They were hesitant submitting documentation. And then we also identified areas for staff productivity and closer monitoring from both the sales and customer success side. We placed a quota mandate on the customer success team to ensure that our team is working hard and diligently and productively in Q4. And so we continue to really look at production and working together from a growth and customer success team to ensure that we are hitting our retention goals in 2026. There are certain levers and strategies that we are implementing in 2026 so that we could confidently hit the 80% and get closer to the 85% mark.
So do you want to provide a little more details?
Sure. Yeah, so we're doing a multi-pronged approach here on addressing this. It's a combination. I mean, certainly there are some headwinds that we face, but internally we're looking at it from an operational perspective. What is it that we can do differently to see an uptick? We are looking into various things. One of them is analytics to look at who do we target the most? Are we targeting the right membership? Are we going after them all sequentially, or do we say this is a population that's more likely, let's get them up earlier, let's get them up later? However, we need to decide. So we're using a combination of internal analytics as well as looking at outside vendors as well to help with potentially the analytics. We're looking at geographic presence. Do we go into certain neighborhoods? Because we do have a geographic hotspot mapping to see that this neighborhood has not had a good recertification rate historically. Let's put more presence there. Let's get the vans out there. Let's get people out there. So we're looking at many ways of doing this. And then another thing is, do we specialize within our teams? Do we specialize certain pods, the more complex, the HRAs? Do we put specialized people on the team so that they can only focus on that and not be distracted by anything else? So these are just some of the factors we're doing. I mean, it's about 14, 15 initiatives that we have going on. We're working on them. They're all happening in parallel. Some of them have a little longer lead time to get to steady state. Others can be started on immediately.
Just the line just continues to trickle down. And I think about, we're going to have to do biannual certifications, not long from now. So if there's something, I mean, we need to be working now to figure out many of the options that you have mentioned. How do we get people to recertify? Because this is going to, is it 27?
Yeah.
27. We're going to start over again. It's going to be every 6 months, which is
It is.
100%.
And we are looking at some technology solutions around that. We're talking to vendors, we're talking to, Microsoft, for example, gave us a demo of something they can do, maybe not exactly what we can do, but we got some ideas from that, hey, maybe we can do it this way. But a lot of, just to give you an idea, they did something for a vendor, for another plan, and to get them ready. And it's very much AI calling, like, they have an automatic, like, hey, we're gonna call you, walk you through the process, and then you just press one, say, hey, if you want to connect to a human. But the idea is that to handle that volume,
Right.
just other than doubling your staff, it's certainly you have to use technology in some way or the other. I think one of the things we can do is we can do a better document collection method. We're working on that as well. That's another initiative we're doing, how to make that easier. That'll go a long way. And of course, better outreach. We're looking at all of those, and we're very, very aware of how much burden this is going to be.
When this initially came up, I was wondering if it was possible to, I'm not sure how I would describe it, but you know how you get information and like from your credit card?
Yes.
Has anything changed? If
Yeah.
not, just ignore. I know you need a signature or something from them, but it's possible to push out information, and if they don't get back to you, or just ask them to sign it and return it.
Yeah, so we're exploring bi-directional text communication where we will be, so it's an exploratory phase where we're pushing them information and we're asking them to respond to us. And we're also checking on the back end, have they done what they need to do? And if not, then there's a follow-up. And if not, that is, I mean, it's early on, but we have to, I mean, everybody in the country has to use technology because this is not, it's not doable otherwise.
So the state systems are in place so that they can implement this I'm just curious, because it seems like that's gonna create a lot more work for them.
So what
also.
the state is doing in preparation, anyone who is not on NISO right now will be moved into NISO. So that's what they're doing. So there isn't this convoluted process around HRA research. Right. The only thing is, I think Roger reminded me, because they've been gradually moving people from HRA into New York State of Health. In that process, we were losing members. It was not a clean process. It was not a one-to-one, and people were
changing through that process.
right. Well, and also they were changing, they were lost in the shuffle. So on one hand, we're excited about it because this bifurcation, some people are certified with HRA. So, I mean, and Lila can tell you, HRA is always more of a challenge because of the population, because of the manual process. So generally speaking, we're excited about the fact that everybody will be on the same process. It's about time. We're just worried about the transition.
There's a lot of hiccups.
Yeah, I'm sure.
And the requirements of the state are also significant. To the point you were making, they do require, the state will determine, do we need the documentation? We have to collect it. We can't keep it for too long, so we can't even reuse old documentation. So there's limitations that we have imposed by the state.
And so for the expansion Medicaid in 2027, if you are a single adult, no children, no disabilities, you have to prove you're working or volunteering. So in order to stay on with Medicaid, so there's going to be a lot of different categories for which we have to understand that population.
Do you have to implement that?
Well, the federal regulation specifically said that plans should not be implementing it, but the states are figuring out how to use the plans and still to be compliant with that ban from the federal government.
Yeah, so there's a lot of, we're watching out the regulatory directives that are coming down, and how do we use that as we build out our strategy for 2027 in partnership with the vendors that we are looking to partner with.
And then you overlay on that EP5 going, and is that 34,000, 40?
Yeah, 34 for us.
34,000 for us and 400,000 for the state.
450. Yes, and more to come, right? This is not the end. It's the start. It's a starting start, but it's the start. So you're right to focus on it. I will tell you, the company works in kind of two lanes. One is new critical efforts, and that's Health Edge and BPAS, et cetera. The other one, and that's top priority. The other one is keeping the lights on. And then the keeping the lights on, number one priority is retention by far. 1 through 20 is retention. And then everything else. top priority. Everybody around this table and way beyond is thinking of how are we going to improve. This is not acceptable. It's not acceptable to us. You shouldn't be seeing those numbers. We shouldn't be presenting those numbers. We're not happy about them. And we're taking it very, very seriously because you're right. If we do not reconfigure ourselves, it will get worse. We can't allow it.
Research is just traditionally, though, a very difficult thing to put your arms around, especially when it was bifurcated. I'm hoping that some alignment will help it, and maybe they'll come up with some creative ways to help as you move forward. But this is going in place 2027, so if it hasn't come out yet, maybe it's not.
Well, and also imagine if they continue to insist that any switches, you have to call their call center. Now, with twice a year, they're not gonna double their call center. The wait times frequently are insane, half an hour, 45 minutes. I mean,
Yeah, it's
gonna
not good.
fall
That's
back
why I
on
was
us.
wondering what the state was doing, because I can't imagine them implementing biannual recertification.
I mean, they will have to explore technology as well.
They
There's
have
no other way to handle it.
There's other things, there's delays in processing and reviewing documents that are uploaded. So for people who owe documents, they're submitted,
And they're sitting there.
there's delays, and we've sent tons of cases to the state where there's delays. There's inconsistency, so depending on who's reviewing, some accept it and others don't. So even in their own rules about what's acceptable, you have inconsistencies with who's reviewing it. We sent cases to the state on that as well. So, and then the long wait time. So we're dealing with a lot of operational challenges that are separate and apart from the federal changes that are happening as well.
Yeah.
And going back to what you was talking about, when they moved it the last time, they set up an account, but the person still had to meet with a CAC to take action on it. So when they moved people before, it wasn't like they moved them over. You now have an account, it's your account on a dashboard. It required intervention from a facilitated enroll.
Oh.
So you would think it would just transition over. You have an account, you're up and you're
Yeah,
good.
yeah.
It doesn't work. It didn't work that way the last time.
That would be too easy.
You had to be.
So that would be, that's an impediment right there,
Yes.
having to.
If it happens the same way the last time, it was.
So are they publishing, or are you aware of other recertification rates across other plans?
We are aware of one other plan that we usually look to, and they have done better than us in 25 in a meaningful way. So that's how we know we can do better. It's not, yes, I'm not denying it at all. There are meaningful headwinds.
Yeah.
Meaningful headwinds. Can we do better? Should we do better? Yes, and we will.
Okay. So I guess we could, in addition to recertification, retention also includes disenrollment mitigation. And as Masood had mentioned, that we are partnering with a vendor. We're looking to partner with a vendor to do consumer profiling to identify members who may be at risk of disenrolling due to a dissatisfaction. If you go to the next slide. And then also this vendor will also be able to help us categorize members in the recertification arena too. Those that are going to recertify by themselves, those that are needier. So that's something that we are doing in 2026. In 2024 versus 2025, we had the team focus on easier wins on the involuntary disenrollments, focusing on premium billing, invalid address, missing documentation, and saving them from disenrolling. In addition to that, in August of 2024, we rolled out a disenrollment survey to all of our members who are up for disenrollment. And some of those members did not realize they were disenrolling, so they reached out to us and we were able to also save them from disenrolling. So overall, from a involuntary disenrollment, we were able to mitigate 0.5%. And we do hope that as we continue to strengthen our analytics and working with this partner vendor, it will continue to save disenrollments from happening altogether outside of recertification efforts. Next slide. So a lot of this we already went through in terms of our 2026 retention initiatives. We will be out in the communities. We'll be also looking to launch an in-person home visit, particularly for those that are the needier population. So for PIC HARP members are very transient, as well as our PIC members. We're also going to be leveraging our provider partnership, identifying providers that have a higher attribution MetroPlus members, and their recertification rate is not to where we need it to be. So we're going to be forming closer partnerships with those providers and working together and getting the recertification rates up. If you go to the next slide.
Yeah, we're doing this already. We just need to do more.
So in preparing for the HR1 impending changes that will be happening in January 2027, we're looking to continue to streamline our operations. No, we want to do less outbound calls. We want to increase our inbound calls. So we're going to send out more text messages, customizing text message saying, hey, you're disenrolling, we have a bad address, please give us a call. You look like you have COB, premium payment is due. We're going to encourage our members to call us, because once they call us, more success rate. So we're doing that, and also implementing IVR calls to let more of our members to do more automation as opposed to calling members ourselves. And then we're developing communicate. So this will then free up our resources to really focus on recertification. So that's why we're trying to do these operational enhancements that we are putting into play in 2026. And then we're developing a communication plan and a strategy to educate our members of the biannual recertification that's about to come and the impacted members.
Mark, what's your experience with the recertification, if you're comfortable sharing?
Wonderfully easy. It's all kind of handed to me. It's easy to know what I have to do, and it's been one of the nice things about all of that, that it's pretty simple.
You do it online, or do you do it with an individual?
A lot of it has happened automatically. A little bit online and some calling, but mostly a lot of it has been done for me already. Like they've already said, this is all done. Your new enrollment is coming up, and it's pretty easy.
How about uploading documents?
No, I haven't.
You didn't need to upload anything?
No, because that would be trouble. I mean, for me.
Yeah, and for many.
There is a button in NYSAL where I believe for auto renewal, and then you click on that and you just have to test for a certain number of years. So we want to look and see how many of our members can be utilizing that, and what does that mean for 2027. So that's an area that we are looking into. So maybe Mark, you have that luxury doing auto renewal. So that is something that we are looking into for our members.
But I think that's one of the things that's going to be changing in future times, that the auto renewal will not be available like that anymore.
So they would have to test.
It just seems like they would have to have a way for people to attest. I just can't imagine that that's gonna go away.
Because the state,
After calls, that was
Yeah.
something that was brought up.
the state themselves has a lot of operational issues and the wait times and system issues and delays. And so it impacts our efforts as well. So imagine it's going to double.
Right,
So,
that's
yeah.
why I can't imagine them not allowing auto renewal. For the premium payment, I was just curious when I was thinking about that, like for QHP and for CHIP. You have like all of those systems in place, like auto pay and all of
Yeah.
those things in place, and triggers that go back to people like you missed your payment and you, okay.
But we still saw people weren't doing their premium payments. And so we knew that when we made the call, we saw a higher success of preventing the
Oh.
disenrollment. So we focused on that, because
So
those were
people
easy
like the
wins.
phone
Yes,
call.
those were
In
easy wins.
26 QHP, we saw a spike in folks that will be
To pay.
disenrolling because of the subsidy.
Um,
Which right, they're now on the hook for the subsidy.
Yeah.
It becomes untenable for some folks on the ACA line.
Ah.
Our average premium there is about $600-$700. Yeah,
Really?
ACA, yeah, got up there.
And the lowest
Uh,
metal
It went
level-
up that
the
low.
lowest metal level is around 600.
Yeah.
Wow. I didn't
So,
realize it
you know,
was that.
as the year is gonna progress, the ACA individual will continue to become less and less stable.
Yeah.
And then on the chip line of business, we have a very small percentage of full pay population.
Right.
So that, that function of itself keeps the numbers low at risk. But we do have the reminders, the text messages, we have the technology to have them set up reoccurring or on the spot or even call in to make their payment.
There's gonna be so much churning.
Oh,
I'm
boy.
just wondering if the state, those, like, the enrollment parameters that they have, they have those still, right? Like, if you come back within 90 days.
They're
with
strengthening that though.
continuity,
It's
they're
90
strengthening
days,
all of
but
that.
they're cutting back on some of those, like, they'll go from 90 days to 60 days.
Wow.
So those are changing as well.
But this is all, it's all coming from the federal government.
Some of it is. Well, I guess most of it is.
A lot of it is. So the state just kind of needs to figure out how to deal with it. It's a lot of those really awful decisions are coming from above.
Should we go to the? Okay. So the call center, we are seeing a decline in the call center. That's due to continued operational improvements coupled with a declining membership. And the top 5 drivers, or the common top 5 drivers, is just general inquiry, medical ID card requests, and PCP changes. We did see a surge in calls because there was a blip in our Incon Flex Card rewards program on the Medicare side, which we'll get to the next slide in terms of the abandonment rate. If you go to the next slide.
So do you want to talk about what worked? I mean, there was a lot of concern in the past and we stabilized. Want to talk about what worked to stabilize the call center?
Well, a lot of it is training. We have, for one thing that's worked very well is we've established a wiki page for information. I think this is a big win for all of us. I mean, and it's updated regularly. So what that does is the customer service representatives, they have access to a lot of information, but it's easy to use. It's right there and it can be updated immediately. So if today we find out that there's a regulatory change or something that's happened in the news, a message can be sent out to all CSR at the same time, and then the wiki page is updated. That allows them to have accurate information immediately. Sometimes we may send out a message inadvertently. Something might happen. We need to update everyone. We get it out there. And then whenever now they want to look it up, it's there. The updated version is there. This allows us, number one, to be accurate with information, but then it's also the accuracy lasts a long time. People don't have to call back and say, hey, you told me something wrong. So I think that's one big advantage. The other, we're doing a lot of training. We've done, we've also created, we have very high NPS scores as well. I mean, that goes along with this. Part of it is we're doing a lot of post-call surveys. We're doing a lot of action. We're working very closely with customer experience on a lot of activity to get the best out of the members, to give the best to our members. So that is happening. We're seeing that there. In terms of more operational things, we've also done a pretty good job with hiring as well. We've had, there are people, lower performers. We've had, we've worked on that. We've done a good job there. So we've done a lot of education on average handle time to reduce our average handle time. At the same time, you can't reduce your average handle time too much because you don't want to quickly answer shut off calls. So I think those are all helping. We've done good staffing. We're doing a lot of realignment as well. Sometimes we have dedicated teams for different LOBs, especially Medicare. When we see our Medicare, generally it's very good, under 5% abandonment rate regularly. We will move those people to other lines depending on the calls, depending on the call volume. Finally, I'll also add that we've expanded the use of our overflow vendor. We've added an overflow vendor to handle a lot of the calls. And we've also expanded them to after hours. And before, after hour vendors would just sort of take a message for the most part, handle a few basic things, take a message, and customer service would handle it the next day. This expansion that we've done allows them to actually address those calls fully, so that it's two things. It's a better member experience after hours. And the next day, customer service is not burdened with, hey, we have to go through all of these. We've really made a big focus on also outreach and very special, anybody quality score where we are not ranked, we're not rated well, that member gets a phone call. We are very, very on top of that. We are doing a lot of things, both from a customer satisfaction perspective and from an operational operational perspective that we are seeing. So, I mean, that's helping. But it's constant work. We're never gonna
And
stop it.
I'm just gonna add from an operational standpoint, we worked with the IT team. A lot of our mails was being returned because the address that were coming in the state, we weren't capturing it correctly. And so the apartment number would be left
Yeah.
off and we get return mail. And so our IT team was able to truncate the address. And so we're seeing less return mail and members are getting their ID cards. That's number one. So less volume. Number two, recertification was a top driver of calls because they were getting letters and they were calling us. And so that sort of normalized. And then number three, we're no longer sending as much cards going out because of the PCP. Remember, every single time we change a PCP, a card will get issued. There are specific product lines where we're no longer listing the PCP name on the ID card. So every single time we do a PCP change, a card won't keep on going out. And so that also minimized the number of mail coming in. So those are just some of the operational changes that we put in place in late 24 that bled into 2025 that also help with the volume of calls coming in. And plus we're pushing our members to use those self-service tools as well.
And with that self-service, I mean, the other thing is member portal offers a lot of things. Another thing we saw last year is we've had some issues with member rewards prior. With the new vendor, it's been a lot better. But even with them last year, initially there were some things, and those have all smoothed out as well. We work very closely with the vendor on those and try to, that all that leads to, reduced call volume. So that's a good thing.
So in other words, we didn't just get lucky.
A lot of work went into it, a lot of operational.
You know, I remember last year, all of the work.
Yes.
Yeah.
Discussions around trying to reduce.
So the needle was not
Yeah,
moving.
it's
It was
moving
not
now.
moving. Now we see.
We're seeing it.
And that's why I think it takes time too for some of
Yeah.
these activities because some of the questions that I ask, it's almost like you need at least a year or two before you can really see the effect of it.
I look forward to hearing about the home visits. That's a very curious idea. It's a fair investment of time. But hopefully, depending what the outcome is, you'll have a chance to secure a member. And I know you're targeting it to specific groups, which is smart.
The reason it came up was because when we had the PPL transition, right? It was very important for us that everybody will get transitioned and people will not be just left without services. And so we've done outreach, text, calling, emailing, mailing, what have you. And we still had a chunk of people who we couldn't get. And so then we started going to their homes and we found them there and we were able to help them transition. So that's where it's stemming from. We've done this, several months ago, and we saw that this population that's not responsive can still be reached to some extent by a home visit. It's not the same numbers. It's not the same magnitude by any stretch. And we have to be very, very smart about where we're investing this effort. But we saw it yielding results.
Next slide. So this is our member abandonment rate. You'll see is normalized pretty well in 2025. In 26, we opened up the year at 6.9%, still significantly lower than prior years. Regular New Year phone calls, but then we did have a blip in the rewards cards. Our income vendor processed the 2025 eligibility file and 2026 eligibility file, and they accidentally terminated records incorrectly, which caused a surge of calls over the weekend that was unexpected. We quickly worked with the income vendor to get that fixed. It only lasted about two days, I think, and we were able to then work with the members and make sure that they understood that the flex card is normal and they should be able to continue to reap benefits of the rewards program. Next slide. On the provider side, we did see a surge in calls in January. I expect this to happen in February as well, all due to the reasons I mentioned in the earlier slides. There was an EDI file delay, system configuration, and other system issues. So could we go to the next slide? Because of the surge in calls, we saw a surge in the abandonment rate. We normalized to hit around 7%. Our goal is to hit 10% below. And so we were at 15.1% again, and I do expect to see that in February as well. We're working hard to get that back to below 10%. I do also want to just call out too, from a provider experience, we sunsetted the the claim call center on the provider side. And that has been really beneficial on the provider experience when they deal with the Metro Plus as well, because they're only talking to one person and not being transferred. So that's been great. And that's where you see the blue in 2024, the surge, because we had to do the transition, train the staff, and now it's stabilized. And I think the provider experience has been a really good experience. And so, continue to do more operational improvements throughout 2026. Next slide. So from a quality, our NPS scores continues to do well. January is 61. I think everything that Masood had mentioned, just working really hard with training, quality, morale. And so you'll see that it's a 57, 57 for January for Medicare. And then I cannot see that for 61. I cannot see the blue for January.
65.
Yeah, 61. Yes. Okay. And so we continue to do well. I think we're above industry standards in terms of the NPS scores, so very proud of that. I think Masood has done really great job working with the customer service team and just staying on top of it. Next slide. Okay, from claims standpoint, you'll see that for 2025, we processed 9.68 million claims that came in versus 9.1 million in 2024, so a 6% increase. We did have, you'll see a strong dip from November and December, and that is because what I mentioned about the EDI claim files being loaded later. We did go quiet purposely to support the transition migration of the PIC line of business. If you scroll down a little bit. And that's that. And then you look at the turnaround time. We were able to process claims quickly. 99, 97% of claims coming in, we were processed within 30 days. Even at 15-day mark, we were processing a high volume claims within 15 days. Our providers were happy. They were getting paid quicker. And then you'll see we did have a dip in December because of the reasons what I mentioned. So we fully expect us to continue to hit the 99, 97% accuracy. It was a promise that we wanted to make, and really proud of the achievement that the claims operations team has done under Karen Turner's leadership. Next slide. Okay.
All right. So what does our membership look like? In the first half of 2025, we were doing well and plan membership was pretty stable, but then towards the second half, that's when we started seeing the decline. So we had a 1.56% decline in our membership in a 12-year swing from February 2025 to February 2026. That accounted for about 10,000 members. There were two products that drove most of that decline. First, it was Medicaid managed care, where we had about a 4.85% decrease in membership, which roughly was about 18,000 members, and CHIP that had a 17.58% decline for about 7,000 members. So those two products drove most of the decline in our membership during that 12-month period. There was some products that had growth. EP, Medicare, Gold, and PIC all had positive growth during this period of time. What should be noted is that our forecast for February 2026 was 680,000 members, and we're at 679,000 members. So we're very close to what our forecasted projection was for this period of time. As was mentioned during Lila's discussion, there were some key drivers that led to the membership decline. Medicaid redeterminations contributed to most of it, and people cycling in and out during research. Child Health Plus disenrollments because of household income shifts and churn with family transitioning between LOBs, and then a heightened anxiety of people wanting to enroll or recertify due to immigration and perceived risk with deportation. On the positive side, things that led to some of the acquisition of new members, we focused on specific high traffic and high concentrated EP areas where we could lean in to the EP line of business, and that paid off. We aligned teams with provider services and CBOs that focused on an EP population. We had stronger collaboration with agencies that focused on the HIV and homeless population who qualified for our PIC program. And we increased our EP enrollment through some broker contribution as well. So towards the end of the year, we had a spike with some of the enrollments from the brokers through EP, some disenrolled, but we still were able to maintain some of that population that the brokers enrolled for EP as well. Next slide. So market share, we look at what does MetroPlus's stance looks like in the market share. So we increased market share in the EP line of business, HIV, SNP, Medicare, and MLTC. That's where we saw some increases in market share. The Essential Plan had the highest growth in market share of about 16,000 members, followed by Medicare with 1,400 members and PIC with about 500 members. So overall, our market share is maintaining. I just want to note that there are some lines of business where the overall market is shrinking. It's not depicted here, but the CHIP market share overall, all plans combined, dropped by about 9.9%. That was about 23,000 people are no longer on CHIP anymore, all plans combined. You have other products that had other significant decreases. Medicaid managed care, 52,000 people for 2.2% decline in that market share. And then the HARP product also had a decrease of about 6%. So there are some shrinking markets where there's a decline in overall populations in those lines of business as well.
But generally speaking, we looked at our competition
Mhm.
and almost, maybe not almost, I think everyone is declining except for one plan.
Exactly.
So when we're talking about the market share, I mean, yes, the denominator is shrinking in general, as Roger mentioned, but we look at the competition, everybody is kind of sliding down and there is one plan that slides up. So in general, whatever market share that everybody is losing, that one plan is picking up.
Mhm.
And you think that's by network, reputation,
Yes, and
Mhm.
yes,
both of those things?
yes,
Mhm.
and yes, yeah. Anything else?
Well, there's awesome, future things that I'll talk about in our next board meeting in more detail, but we are doing some reorg within our department to add on some additional support for acquisition purposes. We're looking to bring on some people who would focus on business development a lot more. We're aligning with Health and Hospital we're talking to central office and Health and Hospital about us piloting a first pass screening where our staff, the MetroPlus facilitated enrollers, will screen all patients coming inside of H&H in Gotham so that we can have the first pass at screening them, seeing if they're eligible for MetroPlus products, and then letting H&H financial counselors do more of the H&H options and emergency Medicaid stuff. We did this before in the past, and we want to revisit that again because we did see some facilities where the work being done by the financial counselors, they did more to Health First than they did to MetroPlus. So we just want to
Let's not
Okay,
go into specifics in a public meeting.
Sorry about that. So we just want to work with them more closely to be assist them with the financial screening of patients coming to the hospital.
Great.
Valencia, do you want to keep on going?
If you could briefly go through yours.
Yes, I'll do it as quickly as I can. So just a reminder, we launched Salesforce Marketing Cloud in back half of 2024. It's a customer relationship marketing platform that is the engine behind real life experiences. So if you ever just purchase something, put it in your cart, you don't buy it, you'll get a series of messages that get you to the end game and then continue to serve specific offers to you, and everything that you see happening to you is a CRM that's powering it on the back end. Next slide. Prior to moving to SFMC, we had a vendor who didn't deliver the best experience for us. It was expensive. It was very slow, took about 4 weeks to write code and send a message. You can imagine we cannot wait 4 weeks to send messages quickly. They were simple messages. It was a one-size-fits-all message. You'll see it on the left-hand side. Limited reporting, very hard to see what was working, and no one really keeping an eye on everything that they were doing, which could then create abrasion with consumers. So we moved to Salesforce Marketing Cloud, next slide, in 2024, 2025. It's become incredibly cost effective. We can actually send a message in 3 hours or less A complex message takes no more than 3 days. It's much more personalized. Our messages have your name on it, so it feels like you're special. Our messages, you won't see this on the right-hand side, are also MMS, which is multimedia. So they're pictures and words that actually flash on your phone. We did that for Gold last year, and we want to do a little bit more of that. I mentioned they're customized. The data is in one place, so we have clear performance reporting, and we have a 4-person MarTech team that runs this day in and day out, and they're really sharp and doing a really, really great job. Next slide. So what does this mean? You know, success is in all of the numbers. Our savings by moving to SFMC was about $800,000 last year. We reached more than our 700,000 members, so individual members and family members, so it was a unique number. We've managed about 70 different types of messages. From an engagement standpoint, 9 out of 10 texts or emails are sent. So that means the quality of our data is good, which is important. We have 1 out of 5 members that actively engage. With all of the messages that we send out, we have little to no opt-outs, which is pretty unbelievable. We thought people were just going to be calling, reporting it as junk, not happening at all. So that's really good news. And just to remind everybody, we had 2 official journeys that we send out. Every new member across every LOB gets a 90-day onboarding journey that talks to you about different things you need to do in your first 90 days. Register for the portal, choose your PCP, learn about your rewards. And we know which ones work better than others, and we just refine them as we go, as we learn about what's working in terms of what you click, what you respond to, et cetera. And then we have recertification journey, which is a 3-month journey, which enhances everything that sales and customer success does. And recertification, we've seen with the new journey, because we prime people a little earlier, gets people to actually recertify a little bit earlier. So 2 very important journeys. So next slide. So now, what are we doing this year? This year is just the fundamentals. We want to make sure that we develop our dashboards, that we're tracking data accordingly. We want to continue to personalize and use omni-channel expansion, maybe things like WhatsApp. We'd like to use some predictive modeling, because right now when we send a message for onboarding and recert, it's one size fits all. It's everybody gets the same message. If we could predict or know something about you, let's say for Gold, we know you didn't sign up for rewards. What if I could send you a message that says, we noticed you didn't sign up for rewards? So using predictive modeling to be more focused. And then one last thing we launched is our 3rd official journey, which is a lead generation journey. So today, when we get leads through sales, sales will call them. What we're helping sales do now is nurture those leads. So sending the person a text and or email telling them it was nice meeting you, and reach out to, John Smith to learn more about the plan. We launched this, Roger left the room. We launched this about a month ago as a test, and we already have a 10% conversion on every single lead that sales sends us. So the goal is sales has to put their leads into Salesforce. We can nurture them in a journey, and we want to do this across the board. 10% is huge for us. Every single lead matters. So we're super excited about that and going to continue to drive that more. And last slide, what does the future look like? The future looks like utilizing AI and predictive modeling. So it's not a one size fits all. We can identify something that you've done, and then we can reach out to you and specifically say, hey, we see you had a PCP visit. Hope it went well. Can you rate the provider? Which then serves for an enhancement on our provider directory. All the little things we could do with AI would be phenomenal.
Interesting. Well, great, thank you. Okay, I think those are all the slides, right?
Yes, we made it.
Made it through. Thank you. Yeah. I think predictive modeling is gonna be applicable in almost every area you're going in. Research, the at-home visit, all of that is going to help a lot.
So we are in active talks. We both have some internal capabilities, but we're also in active talks with vendors who do that for us. Yes.
AI is the way of the future.
It is. Of the present.
Yeah.
It's how this is going to impact more reason why we have to leverage AI. Is it adjourned?
Yes.
Oh, wait, you have to post.
We just need to close
Oh,
the.
I'm sorry. The meeting is adjourned. Thank you.